Hello everyone, welcome to Style Italiano Endodontic webinar series with me Marino Sutedjo from Indonesia. It is a pleasure for me today to share with all of you in this webinar about how we can enhance our root canal treatment, especially in our instrumentations in daily practices for endodontic treatment. So if you are talking about endodontic treatment, we all know that the final objective of our endodontic treatment is, of course, tooth retention. We want to retain tooth as long as possible without any symptoms and functioning normal. And we know from the literature that these things is possible to achieve. This paper back in 2004, how they study from more than 1 million teeth and more than 1 million patients, retaining tooth for more than 8 years can be achieved with 97% of tooth retention. So we know that this goal is really possible to achieve in our endodontic treatment procedures. This is some of the case that I'm doing for my endodontic treatment. How can I achieve from 18 years tooth retention without any symptoms and the tooth is still functioning? So how this can be achieved, of course, the key point of this is how we can eliminate bacteria, because we all know majority of the endodontic problems of the endodontic failure is caused by the bacteria. Either the bacteria survive persistently or the bacteria is coming from the secondary infection. But we all know the key point to retain the tooth as long as possible without any symptoms is how we can eliminate as much as possible bacteria inside the root canal systems. And how we doing these bacterial eliminations? Of course, from doing root canal preparations. As what Schilder said, that root canal preparations, it means by we are preparing our root canal to be obturated. So it means if we are talking about preparations, it means we are talking about shaping and cleaning, because these two procedures, shaping and cleaning, is the one that can eliminate as much as possible bacteria inside the root canal systems. And if you are talking about the preparations, it means shaping and cleaning, the rationale of course is clear. Unshaped canals of course cannot be cleaned, and shaping means we are creating volume to facilitate cleaning, and we do shaping with our instruments. So if we cannot do our shaping up to the apical portions of the root canal, it means we cannot deliver our irrigants into the apical area. It means the eliminations of bacteria might be resulted not in a good way. So we know from the shaping and cleaning rationale, we need to have a good shaping up to the apical portions of the canal in order to create volume, to create space until the portions of the apical area in which the cleaning irrigants can work and they eliminate the bacteria and also the tissue all inside the root canal systems in a good way. So by meaning of the shaping, we know also from Herbert Schilder the 5 design objectives of the shaping. It is continuously creating a funnel space from the access cavity into the apex area. It means the cross-sectional diameter should be narrower every point apically, and we should not change the apical foramen positions. It means we still need to maintain the original shapes of the canal. And last but not least, we should maintain the apical foramen as small as practical, not as small as possible, but as small as practical, because we know the size of the apical preparations is vary from one tooth to another. So how we can create this 5 design objective? Of course, by creating taper instrumentations. It means taper instrumentations, we can maintain the root resistance, we can improve our irrigants efficiency because of the taper of the funnel shape, and it create a good apical stop for our obturations. It can be improving our obturations as well as visibility inside the root canal systems. So we know if we want to create a good shaping, it means these 5 design objectives we have to apply in order to create taper instrumentations for our root canal systems. And how we can achieve this objective, of course, there are 3 phases that we are doing in our instrumentations protocol. What is these 3 phases? Is the first phase is the negotiations of the root canal, or we also can mentioning a scouting of the root canal systems. And then we need to determinations of the working length, and the third phase is of course the enlargements of the body of the canal. So first phase is the negotiations of the root canal. So what is actually the definitions of the negotiations of the root canal? It is the explorations of the original shapes and the curvatures of the root canal systems, and how we are going to do these negotiations, and by using a small diameter file as an initial file that goes into the root canal systems with watch winding motion. So what I mean by small diameter file, it means either you can use number 8 or you can use number 10 as your initial file that goes into the root canal systems and in watch winding motions. It means 90 degrees and clockwise, and then goes with the 90 degrees counterclockwise. So passively insertions of this K file with watch winding into the canal, and continue with slightly in and out motions to smoothing the root canal until we can have a smooth pre-flaring of the canal in order to create our next step shaping phases. So you can see here, after I reach the working length, I'm creating I'm smoothening and pre-flaring my root canal systems by doing it in and out motions with the K file. So this is the first phase that we should do in our root canal systems if you want to create our instrumentations, by creating or by doing negotiations with the small K files into the root canal with watch winding motions to create a pre-flaring to go with the next step, which is the glide path. We often heard terms of glide path and in negotiations, but we need to understand that these 2 steps are completely different. Negotiations is not glide path. Negotiations is the first step that we do in order for us to create a glide path. And what it means by the glide path is the creations of the root canal wall with a smooth wall without any irregularities that works as a guide for the rotary tip files to slip and slide into the root canal system up to the working length, or up reaching the apical area of the root canal. That is quite important to achieve, because if you are unable to achieve or goes into the apical area, we might not have a good shaping protocols to create a good space for the irrigants to work inside the root canal systems. So how we can get this glide path? Of course, we can achieve glide path into two different ways. First, if you want to use your manual files, or secondly, if you want to use your mechanical or rotary files. I still remember when the day we don't have any mechanical files to create glide path. We still need to create a glide path with manual files. We know it is not predictable to achieve, and we know if you are doing mechanical glide path, we gain more advantages comparing with the manual glide path. We know from the literature, this is from the 2012, that the rotary glide path create less post-operative pain because we create less debris extrusions with rotary comparing with the manual files. Because you know with the rotary files, because it has a continuous rotations, the capability of the rotary files to take the debris from the apical to the coronal will be easier comparing to the manual file, because we know with manual file we tend to create more extrusions with the debris outside the apical area. And not about only the less pain from rotary glide path, we know also from this study, the Giuseppe Cantatore and also Professor Berruti and Castellucci, they are divided into 2 operators, which is expert and inexpert, and they are also dividing with the manual gliide path and the rotary gliide path. And what we can see here, if using the rotary, both expert and inexpert, they're still able to create a smooth shape from the root canal systems and not to have huge deviations from the root canal system itself. You know, from the inexpert group, there is a slightly enlargement at the apical area comparing with the expert group, but in my opinion, it's still acceptable. But when they are both using the manual gliide path, you know how big the deviations, you can see how big the enlargement at the apical area, even though in the hand of expert. And this enlargement also create more debris extrusions. That's why it will create more post-operative pain. Comparing the one, if you use the rotary file, we can still maintain a good apical enlargement to reduce the risk of debris extrusions outside the root canal systems. So you can see, if you try to make a gliide path with a manual file, because the stiffness of the stainless steel files and the cutting tip of the stainless steel files, you can see that slowly it cannot pass beyond the curvature, and it will create an elbow. Also, we know there is a big chance of creating a ledge. And once this conditions is established, it's quite difficult for us to gain a few millimeters below this ledge portions, because it is already creating deviations in the root canal area, specifically in the curvature. So we know now, if we are creating a gliide path, a good gliide path also will reduce the risk of debris extrusions. In this case, if we are using a rotary gliide path. And with rotary gliide path also, it will improve the preservations of the original anatomy, and it will reduce also the risk of file fracture. And from also many studies, we know now that the rotary instruments for creating gliide path, it will promote less deviations comparing with the manual gliide path. So if you want to create your gliide path after your negotiations phase, which path you want to choose? A nice and easy and safe path, or you want to choose the more dangerous and risky path? I will choose definitely all the time the left side, which is an easy and a safe path into my apical area. So now you can see how, if we change into the rotary gliide path files, it will easier for us to reach the apical area and to pass the curvature, because the design itself, because it has a continuous rotation, so it will easier for the file to pass beyond the curvature without any risk of creating ledge or deviations inside the root canal systems. So now we know the first phase is the negotiation. By means negotiation is creating a smooth pre-flaring using your small files, either number 8 or number 10. And then from that negotiations, you can continue creating your gliide path by using your mechanical instrumentations to create a safe and smooth and reproducible gliide path up to the apical area. And the second phase of your instrumentations protocol is how you can determinations of your working length. We know the working length, it is quite important, because one of the factors for the tooth to have a long survival treatment, one of them, if you have a good root canal fillings up to the correct length. Because we also know from this study, it is important to understand in teeth with the apical periodontitis, if you lost a millimeter loss in the working length, you may have increased the chance of treatment failure by 14%. So we know if we miss 1 millimeter of the working length, we have a chance of increasing our failure rate by 14%. So in this context, we know how important is our working length. It means by the working length, if you can create and if you can measure a good length and stop at the correct length, It means we can have a complete debridement of the root canal systems. We can establish the distance of our instrumentations and can complete our preparations and obturations and not creating a traumatic to the periodontal ligament spaces. So therefore, if we want to measure our working length, we should know where should we stop. And the stop point of our instrumentations is at the apical constrictions, because the apical constrictions is the last dentin area, because below apical constrictions there will be no dentin. It is only cementum. And we know pulp cannot extend beyond the dentin because pulp need tubules to attach. So therefore, below the apical constrictions, there will be no pulp systems there. So if you want to stop your instrumentations, you need to stop at the constrictions because that's where the pulp ended. And below the constrictions, we can say it is goes beyond the root canal, and it is goes into the periodontal ligament. So the where should we stop is, of course, if we need to stop at the apical constriction. And how are you going to measure these apical constrictions? We still know some of clinicians still rely on on X-ray, but I'm going to choose all the time using the apex locator. But I'm going to say why, because the X-ray, it is only two-dimensional X-ray, and we know the apical foramen sometimes is not the same with the radiographic apex. And speaking about the apical constrictions, it is not definitely, it will never be the same with the radiographic apex. So I give you example. If you see from this X-ray, it might see that the working length is short, let's say 1 or 2 millimeter. But we see this only with two-dimensional X-ray. We cannot see the other side and the other angle of the X-ray. Because if we are looking from the other side, what we saw, it is 2 millimeter short. It turns out it's 2 millimeter over from the apical foramen. So because the apical foramen will not be always the same with your radiographic apex. So what you saw, it doesn't 100% correspondent with the reality inside the root canal systems if you rely only on X-ray. Therefore, the apex locator, it is a tool to help us to measure the working length in a more precision and more accuracy comparing to the X-ray. Because we know also from the study, both in vivo and in vitro, the high percentage of accuracy in apex locator to measure and to determine the positions of the apical constrictions, it is achieving more than 70% up to 100% in this study. So we know now we can rely on this accuracy of the apex locator to reading the apical constrictions. So this is how we should do our measurement with apex locator. You want to clip your 5 clip above the rubber stop, and you slightly progress your root canal into the apical area until you hear this sound. This sounds means you are passing through already the foramen. You need to avoid it, and you need to retract your file until it goes into the constrictions. And if you are already reaching the constrictions, you might release your file clip, and you can use your tweezer to measure and to take down your rubber stop, and then you know that is the reference point, and you can take out your file, and now you measure your working length. So apex locator is a tool to help us to determine where is your stop position. But the one who measures the working length is the operator. You take out the file and you measure your file. How much is the length of your root canal systems? So after the determinations of the working length using your apex locator, you might want to confirm with your X-ray, because I think that's the best combinations. After measuring with your apex locator, now you can confirm it with your X-ray just to make sure you are having a safe length into the apical constrictions in the apical part. So the final phase, of course, the enlargement of the body of the canal to create a volume and to create spaces. Let's go back into this small history of root canal instrumentations. We know Back in my dental school, this tools is the one I used to create instrumentations of my root canal. I'm using a stainless steel 2% taper to create instrumentations. But we know the flexibility of stainless steel file is really bad. It's stiff, it doesn't have any flexibility. By mean this, if you want to use inside the root canal, sometimes it's very easy and you have a high risk to create deviations, to create ledge inside the root canal systems. So therefore, in the late 90s or early 2000s, they come up with the nickel titanium era, in which in this nickel titanium we can gain flexibility, we can gain more cyclic fatigue resistance compared to the stainless steel. But on the other hand, although we know many advantages from the nickel titanium, there are also disadvantages from this nickel titanium properties, in which these files, this material, they have a memory shapes properties, in which what this mean by memory shape properties, the flexibility is good. You can bend this 𝗘𝗍 into this position, but if you release it, this file tends to go back into a straight position. This is what we call a memory shapes. So if imagine you are working in a curved canal, the file can be bent into this curved position, but at these positions, they actually wants to go into the straight position. This is what we know about the memory shapes. So some of the cases in curved canal, it will create us also a problem because this disadvantages from this 𝗘𝗍 files. So therefore, I just want to talk about the properties of its nickel titanium. We know nickel titanium is 50% nickel and 50% titanium. Titanium is responsible for the flexibility, and the nickel is responsible for its rigidity. And this nickel titanium, they have two phases. Phases number one is they are on the martensitic phase, and also if the second phase, if they are on the austenitic phase. If they are in the martensitic phase, it means it is the phase that this 𝗘𝗍 become more flexible. But if they are on the austenitic phase, it means that this file, they are on the stiff or the rigid conditions. But interestingly, this phase, they can be turned it upside down by only applying heat. So if you want to be more on the austenite phase, you can heat your 𝗘𝗍 alloy. They will become in the austenite phase. But if you want to go down into the martensite phase, which is more flexibility, you can cool down this 𝗘𝗍 alloy, and it will be on the martensite phase. So this advantage, now we know we can create a new different alloy from this, or new different properties from this 𝗘𝗍, by creating heat treatment into these instruments. So we know from Fanta, they are providing us with many types of heat treated files. They have a slightly martensitic material, they also have mildly, and they also have a highly martensitic phase of alloy. And what you see here, this is the rising files from Fanta, the new rotary file from Fanta. It makes also from ProWire. You can see the memory shapes, it's gone from this file because of the heat treated that is applied. So you can bend even you can bend it in S-shaped curve, and the file will not go back into straight position. And this will give us advantage if you want to create a nicely curved shape for your root canal systems. You know that this file, it will not go back into the straight positions or into its original positions because of this properties by this heat treated alloy. So we know now from the material point of view, we are now in an era that we are having this heat treated material for our instrumentations that will give us more advantage in doing enlargement or creating a volume inside the root canal space without having high risk of deviations. And let's now talk about the manual versus the mechanical enlargement. because I know some of you still doing rotary or still doing manual instrumentations using the rotary file that you put your manual drill and you drill with your hands, although it is a file that's supposed to be used with the rotary or the machine or the endodontic rotary. So let's now discuss about how is the manual versus the mechanical point of view. We know from the evidence also that if you use your rotary instrumentations compared to the manual, you can achieve better efficiency, you can also achieve less canal transportations, and you will also achieve less canal deviations. And also from this systematic review from this 𝗘𝗍 in 2020, that if you use rotary instrumentations, you will have less operative pain, at least 6 to 48 hours, compared if you use your manual instrumentations. So now we know, I'm definitely suggest all the time to all my colleagues that this day we should change all our enlargement protocols using rotary rather than using the manual instrumentations. But there are rules that you cannot avoid if you want to use a rotary in your instrumentations daily practices. First thing first, don't stay too long. What I mean by don't stay too long, it means you still need to move your instrumentations, keep moving. Do not stay in one position too long. Although I know you use your martensitic file or heat-treated file, staying too long, it will also creating more problems. Like you can see, if you put this file into in this position, there will be tension and compressions at the same time, and you see from the timing, it only takes less than 15 seconds for the file to break. So first rule is don't stay too long, because staying too long, it will also increase the risk of fracture and deviations. Second rule is do not push too hard. What I mean is do not push too hard. It's like if you want to write using your sharp pencil, if you don't push, it means the pencil will not create writings. But if you push too hard, the pencil will break. So same things if you want to use rotary. You need to push slightly. What I can say, you need to push maybe small push or two, or you might not to push at all. Let the file goes in and follow the path of your root canal systems. And last but not least, the most important rules, if when you're done, get the hell out. So it means when your instruments already reach your working length, there is no necessity for you to repeat it too many times. So let's see from this video, you can see if you want to use your rotary, number one, it's keep moving. If there is resistance, you take it out and you go in again. But when you stop at the working length, you just take it out and you don't need to repeat it. If you want to repeat it, you can see from this video how the root canal now change the shape. Because if you repeat it too many times, it will create enlargement at the apical area, and it will also destroy the original shape of your root canal systems. From S shapes, now you can create a J shapes. Same things, if now I'm going to use a larger diameter files, keep moving, don't stay too long. If you have resistance, take it out and you go in again. And if you have resistance, take it out. But if you reach already the working length, now you don't need to repeat it. If you want to repeat it one time or two times, it's fine, but you don't need to repeat it several times. You can see from this video, if you repeat it too many times, you will create your own problems, you will destroy your original shapes, and you will create apical enlargement, and you might push debris more apically and create more post-operative pain. So what instrumentations need to meet the challenge? We know now our instruments need to design to give us flexibility and to provide us also efficiency. It can create comfortable, smooth, effortless, and simple to use. And last but not least, also to preserve dentin as much as practical in order to have a longer tooth retention inside the mouth. Today, I have a chance to introduce you the new rotary file system from Fanta, which is the rising instrument systems. which is it has many advantages from its features. It has a variable taper to design the minimally invasive shaping. It also have a special design at the apical area for 𝗍𝘁 cone fit. And my favorite features is this one has conservative coronal shapes at which only 1 millimeter in diameter of the coronal portions. Therefore, it will only create dentinal removal only when needed. And from the lineup, you can see it starts with the RR with the tip 17 taper 10 to open up the coronal portions and to remove the coronal interference. And the first glide path is the R1, which is the 13 size at the tip with the 3% taper. And then it is continue with the R2, which is the 2504. In this sequence, you can stop and you can finish your preparations, or you can also go a little bit larger with the R3, which is tip 30 and taper 4%. So if you are seeing this conservative coronal shape, what I means, if you only have 1 millimeter at the coronal size, it means you can preserve this pericervical dentin area at the cervical part, which is the most important area to have a susceptible fracture resistance or the toughness of the tooth in order to increase the fracture resistance. By having this 1 millimeter, we know we are not removing this pericervical dentin area, because the impact of this pericervical dentin area in this cervical part, it is the highest impact of increasing the fracture resistance. So I have this case. If you see, this is quite interesting case, because the case, the patients came with the 𝗶𝗰𝗰𝗁 sign, acute 𝗶𝗰𝗰𝗁. The patient come in a spontaneous pain. The patients cannot drink, not talking about cold, even room temperature water. The pain coming sharply. But I didn't see any sign of caries. I didn't see any sign of huge filling. There is only a small filling in the distal part. But from the X-ray, you can see there is a calcifications or fibrotic signs in the pulp chamber. So I might have a suspicion it might be something going on. And my best guesses in this case is we are having a crack problem. So as you can see, after doing anesthesia and creating access cavity, we can definitely see the crack sign over there. So if I know now I have a cracked tooth, it means first thing first, I need to remove dentin as I need to save dentin as much as practical, because I need as more dentin as possible in order to have a higher fracture resistance. Also, I don't want to reduce too many dentin portions at the coronal part in my instrumentations protocol. So I finished this with my rising instrumentations. The good things about rising, because it's heat treated, you can pre-bend it, so easier for us to go inside the working inside the root canal if you want to make a conservative access. So in this shaping, this is the distal canal and this is the mesial canal. And in this video, you can see because I try to create conservative access, so I can pre-bend my rising, so easier for me to insert my root instruments into the root canal. And you can shape, in this case I shape only up to rising R2, which is 2504, because I don't want to have a huge shaping, because this tooth is still vital. And you can see the debris at the apical area. It means I already touched the apical portion nicely, because the grease is packed there. So I can stop with my 2504. I can continue with my cleaning protocol and activations of my weekends, because if in the case that you use your R2 and you cannot see any debris pack at the apical portions, that's the sign you might want to increase until the R3. So after activations of your irrigants, then you can continue your obturations. In this case, I'm using my bioceramic sealer with the both compactions. It means I'm using the single cone technique with my bioceramic sealer. And after obturate, this is the final result. And since this is a crack case, as soon as possible I create my lithium disilicate crown just to have a good protection as an indirect protections of this tooth. So this is after the insertion. I make sure all the marginal is sealed nicely, and this is after the post-op x-ray. So we know also from Schilder that they are asking us to keep the apical diameter as small as practical. So if it is enough, you see the debris at the apical part is packed, so you can stop. But in some cases, because it's still dynamic concept, if you think your shaping it's too small and you need more space to in order to have more irrigants inside, then it means you can go your sequence up to R3 or also up to R4. Remember, every time you want to use your rotary instrument inside the root canal, make sure you have a full fluid canal. In this case, I'm going to use my sodium hypochlorite as also a lubricant. Do not use gel lubricants anymore because it will increase your torsional fatigue. In this rising, I'm going to put my engine into a 450 speed with a torque of 2.5, and it will works all the sequence with this RPM speed, and with this also the torques 2.5. So my take-home message today: shaping is a part of root canal preparations, and we have to understand shaping is to create volume because it will facilitate a good cleaning. And our outcomes is not depend only on what instruments we are using, but they are also depending on all biological aspects. So thank you very much for providing your time, and I hope you enjoy this webinar, and I hope you learn something from this webinar. And I'm going to see you in another webinar series from Style Italiano Endodontic Groups. Until then, take care and bye bye.